here.
Okay, so just going through the adductor group. So on adductor longus, add resistance. Okay, and then palpating with the fingers perpendicular to going perpendicular to the fibers. And adductor longus has the anterior and the posterior face.
So in order to get to that position there, he then went medial to find gracilis, which you can find.
And then the cord-like gracilis is just medial to the posterior face of the adductor longus. Okay, walking the fingers down where it becomes part of the pes. If you resist the external rotation and adduction and simultaneous flexion, which would give you gracilis, then you can also differentiate gracilis relative to sartorius. Continuing to walk down.
Then he went
up.
Posterior.
Okay, and then to get to Magnus.
So we're going to switch hands.
You're going to switch the hands so that you're going to come medial to gracilis, and you're going to come in. Notice the amount of force and how the depth of the palpation here. And you can add a layering effect by adducting the leg to allow you to get deeper. Okay, and then coming down towards the table simultaneously. The unique thing about the adductor Magnus is that it's also going to be a hip extensor when the hip is in a flexed position. So it's going to act as like almost a fourth hamstring. Thus, when you're palpating it and trying to assess the tissue, the mechanical tissue quality going into hip flexion and then abduction is going to help to differentiate it off the medial hamstring. Simultaneously using multiple finger pads to assess and compare different lines of tissue within the Magnus to determine where intervention or manual therapy targets can be directed. Okay, final one was the adductor brevis, which is quite deep. You're going to come back up and get your reference point of the longus, and then you're going to go ahead and push medial and then down towards the table.
Yeah, so it's in and then up towards pubic bone.
Oh, yeah, so more of a superior push then. Great. And this one's going to be a little bit more sensitive than some of the other tissues that we've pushed on or palpated. Okay, and then confirmation can be done with resisted adduction. And then for the actual assessment of mechanical tissue quality and tension, turning our fingers parallel to the fibers, again using multiple finger pads, so you have a nice width there to compare mechanical tissue tension versus neurological tissue tension. Mechanical tissue tension would have a non-uniform increase in tension along one line of tissue versus your neurological tissue tension, they would all uniformly tension.